Hi, everybody. My name is Anisha. I am a PGY2 internal medicine resident at Detroit Medical Center, Wayne State University. This is Bourann and Ankit, who are PGY2 residents with me. We're all cardiology hopefuls, and we wanted to start this little video series called Getting to the Heart of the Matter, where we talk about different topics that are cardiology related and adjacent that we're interested in. So today, the thing that we wanted to talk about was the SUMMIT trial, which just came out pretty recently. Bourann, do you want to tell us a little bit about what the trial investigated?
Yeah, so the Summit trial, really interesting trial to come out in the past few months, and it investigates the use of tirzepatide, which is this combined GLP-1 agonist and GIP agonist. In patients with heart failure with preserved EF and obesity to see if there are any cardiovascular benefits. Specifically, they looked at adverse heart failure outcomes and cardiovascular death. And so this is kind of a really interesting trial to come out. As we've seen in the past few years, we're seeing a lot of these medications similar to tirzepatide, like the GLP-1 agonists, the pure GLP-1s, SGLT2 inhibitors, all these traditional diabetes and obesity medications that we found have some cardiovascular benefit in certain populations. Specifically, we've seen a lot of our heart failure patients having some benefit. So we are looking at in this trial if tirzepatide has the same benefit in this patient population and specifically in patients with obesity and HFpEF. So we'll learn a little bit more about it.
Okay. Ankit, do you want to tell us about the study design, how they chose what they did to pick who they wanted to include? Well, not necessarily include, but how they kind of designed this trial.
Yeah, of course. So this trial was an international randomized double-blinded trial that had two groups, the tirzepatide group and the placebo group. And the dose was started initially at a 2.5 milligram dose once weekly, which was escalated every 4 weeks. And then the maintenance dose was 15 milligrams, which was reached by week 20 of the study.
Okay. And how long did the study go on total?
Um, 2 years.
Okay.
I believe 102 weeks was the median.
Okay. So about 2 years. Yeah. And then I'm going to talk a little bit. So basically, the people that they included in this trial was people who had stable heart failure with preserved specifically, so ejection fractions greater than 50%. And
Mhm.
they did not include, which I think made this study really unique, are people that had major cardiovascular events in the last 90 days prior to the screening of choosing them, and also acute any people who had acute decompensated heart failure in the last 4 weeks prior to the screening. So I think that's definitely what's unique. And then they also, of course, excluded people who were quite sick, like people who have end stage kidney disease or who have a contraindication to the medication, like such as having a history of pancreatitis. Um, Bron, do you want to tell us a little bit about the results of the study and what they found?
Yeah, let's talk about the results. So, just to kind of start off, all of the patients in this study did go for at least 52 weeks, either on the placebo or the tirzepatide, although the median follow-up was 102 weeks. But we know for sure at least we have 52 weeks worth of data for all of our patients. And so the primary endpoint, which was the main goal of this trial, was a combined endpoint of adverse heart failure events and cardiovascular death together. And when we say adverse heart failure events, we are primarily talking about heart failure hospitalizations. And so when we look at this combined endpoint, we actually do see a statistically significant benefit in the tirzepatide group. They ended up having a 9.9% event rate of those adverse heart failure events and cardiovascular death versus 15.3 in the placebo group, which ends up being statistically significant. And so we do see a real benefit there in our primary composite endpoint. When we separate them out into adverse heart failure events, we continue to see a statistically significant decrease, 8% adverse heart failure events in the tirzepatide group versus 14.2% in the placebo group. So that's a really promising and exciting finding. However, when we look at cardiovascular death alone, we see that there is not a statistically significant difference. So it was 2.2% in tirzepatide group versus 1.4% in the placebo group. But overall, we did meet our primary composite endpoint in the SUMMIT trial. And so we are able to say that at least from this study that in these patients, they did have a benefit in adverse heart failure events after using tirzepatide for at least 52 weeks.
Thank you so much for sharing. I think that's honestly one of the most important things is that I think we focus on always mortality, but having an improved quality of life is also something that's really important to our patients. And I
Yeah.
know that, especially for our patient population, I think that reducing the number of hospitalizations would significantly improve the quality of their lives because we have a lot of socioeconomic factors and specific barriers like transportation and just ways that they can't get to the hospital. Ankit, do you want to talk a little bit about kind of the long-term impact of this study and kind of questions that we should be asking or that we can be thinking about?
Yeah, so the landscape of medical therapy for HFpEF is actually pretty limited. We were talking earlier about how there's only like three drugs, like spironolactone and Entresto, which are both class 2B recommendations, and then Jardiance or other SGLT 2 inhibitors that are class 2A recommendations. So adding another medication to that toolkit is always really, really important. The way we were talking about it earlier, kind of making it as an analogy to digoxin, how digoxin reduces hospitalizations but does not impact mortality in HFrEF, and we see the same kind of similar effect in Tirzepatide and HFpEF patients. The one thing that we were talking about earlier is trying to understand this on a more granular level. And Anisha, what did we talk about, or what did we find about how tirzepatide specifically, like the mechanisms and how it improves some of these outcomes that Bourann was mentioning?
Yeah, I mean, I think that it has three major things that we were talking about. One, that it's GLP and GIP, so it has kind of an enhanced weight loss effect. So I think that that affected the results of this study and the benefits of this study.
Mhm.
Two, that also made so the GLP agonism of the drug also reversed some of the inflammatory impacts of adipose tissue. So we have the weight loss component, we have the inflammatory aspect of the adipose tissue that people are losing. And then on top of that, which I think this part is the most interesting to me, is that there are GIP receptors in the epicardium of the heart, and affecting the inflammation of that as well was one of the benefits that they think is kind of how this drug works and how it's improving outcomes for people with preserved ejection fraction. So I just feel like it's multimodal, and that's really cool because I think that it has a possibility to benefit a lot of people and for different reasons and kind of work, Bourann, do you want to talk a little bit about how, we were talking a little bit about how this trial is different and who they included that makes this, that really sets it apart?
Yeah, so one of the things that we had talked about a little bit earlier is that in recent trials or trials a little bit prior to this one, specifically we talked about the STEP HFpEF trial, which is where they investigated semaglutide, which we know is a pure GLP-1 agonist in our heart failure patients. In that study, what they did is they set a pretty high minimum for BNP levels in their patients as an inclusion criteria. And, the thought behind that was to have patients with more severe disease or more clinically significant disease included in the study. But I think what we notice now, because the Summit trial had a lower threshold, is that probably in this STEP HFpEF trial and earlier trials, we were excluding a lot of patients with obesity, which we know can cause a false lowering of the BNP levels. We were excluding a lot of those patients who probably could have benefited a lot from a GLP-1 agonist or the GLP-1 GIP agonist. And so the benefit of the Summit trial is that we lowered this threshold to 200 in patients without AFib, 600 in patients with AFib. And I think we were able to include a lot more patients who have obesity-related heart failure, and probably the prime candidates to benefit from this because, as we said, weight reduction was one of the ways in which, or maybe one of the primary ways in which we think that this ended up benefiting in the realm of adverse heart failure events. So I think this was a change that we ended up garnering a lot more benefit from. And maybe this is something that researchers in the future can kind of consider if we're going to continue to study these classes of drugs.
Yeah, I mean, I think that thing I hope for is that we can get these drugs approved for our patients and that we can start using them, because I think that they would be really amazing. It's a really amazing tool for us to add to our tool belt. I mean, we've seen how we've started including all of these drugs even through our residency program, even the last couple of years, how we're able
Mhm.
to get these drugs approved and implement them and see less hospitalizations, patients that we've been following in clinic and inpatient. So I'm excited for how we get to use this. Yeah. Any other thoughts, guys?
The last thing that I wanted to add, which just came to mind, it's just so interesting how inflammation is so central to a lot of cardiovascular disease, like atherosclerosis, AFib, heart failure. So it's just super interesting. I hope we continue to um, think about this.
Yeah. It seems like everyone is, and hopefully we are too. And I think that it will make a big difference. So, anyways, thank you everybody for joining us in our first episode. We hope to see you all soon, and we will continue to do these fun little videos. Take care.
Thanks,
Bye.
guys.
Thanks.